Thank you very much. It's a great pleasure to discuss the topic that was already touched a couple of times today. What about the left atrial appendix? I want to separate this into three parts: the rationale for left atrial appendix closure, then what the clinical data we have as far as today, and what we think we can expect in the near future here. The rationale, of course, is that at least some of the strokes we see in our patients with atrial fibrillation are coming from thrombus formation in the left atrial appendix. The database for this is actually quite old, so we know from autopsy studies, but also from TEE studies that in non-valvular atrial fibrillation, about more than 90% of thrombus that we can detect are present in the left atrial appendix. And the appendix seems to be a very individual structure. Everybody looks different, and there have been some recent attempts to link the anatomy of the left atrial appendix to the risk of stroke. You see here the terminology that it's used, and it seems in the more complex anatomies, also a recent meta-analysis suggests from the imaging studies that the risk of stroke may be twice as high as compared to the more simple anatomy of the so-called chicken wing, suggesting that indeed, or giving maybe some further support for the concept that the left atrial appendix is a source of stroke in patients with atrial fibrillation. The question is of the clinical need. We all are, of course, aware that the first-line strategy will be oral anticoagulation, but when we look in our recent clinical trials, also for the NOAC, about 20 to 25% of patients were not able or had to discontinue the drug, clearly suggesting that there are patients who may not be amenable to long-term anticoagulation therapy. And I think very rightly so in the ESC guidelines at present, the recommendation for LAA closure is very reluctant, so only for patients who really have clear contraindications for long-term anticoagulation. And there's also, I think, a very nice table there to suggest or to help suggest which may be patients who are not able to reinitiate anticoagulation after a bleeding. And I think it also illustrates that, for example, the discussion after an intracerebral bleeding may involve in the team between a cardiologist and cardiac surgeon, also neurologist, so to see what is the risk of rebleeding under anticoagulation. So I think this is a very helpful suggestion from the recent guidelines. What clinical data we have. And of course, as you know, the data from randomized trials are rather limited. We have data from the PROTECT-RF study using the Watchman device, and there's a second smaller randomized trial, the PREVAIL trial. Together it's about 1,100 patients. Both trials included patients who are actually eligible to anticoagulation and who were not at particular high risk of stroke. However, the data that we received, and this is here the 4-year follow-up of the PROTECT-RF trial, were rather encouraging. You see here for the primary efficacy endpoint, there was actually even advantage for the device treatment group. And if you look at cardiovascular or total mortality after 4 years, there was also some benefit observed in the device group. So also we have, of course, to keep in mind the number of patients included was very small. They were not at very high risk of stroke. However, the data, I think, still look encouraging. There's a meta-analysis of this trial, and you see for the efficacy endpoint there was non-inferiority. There was also no change for all-cause stroke or systemic emboli. However, there was a signal for more ischemic strokes in the LAA closure group and less hemorrhagic stroke, so suggesting that the protection from ischemic stroke may not be as potent as compared to anticoagulation therapy, so clearly suggesting that this may be a strategy only to be used in patients at very high risk of bleeding. Now we have recently seen more and more safety data for LAA closure. These are the data from the Evolution registry published last year in the European Heart Journal, and you see nicely here that the periprocedural complications are consistently going down from initially about 9% to now in the range of 2.5%. And this is very similar now also in the just very recently published data after the FDA approval of the Watchman device with close to 4,000 patients. We see also here that the rate of periprocedural complications is also in clinical practice rather comparable to what we have seen in the registry data, so in the range of 2.5%. In particular, the range for pericardial effusions is also seems to be also in clinical practice in a wider use in the range of 1%. Now, there are more devices, of course, that have been developed. Most advanced is here the Amplatzer AMULET device. This device has a bit of different design, so it is a lobe and a disc, so the lobe is anchored in the left atrial appendix here. And for this device, we have now data from also a large global registry. It seems from the data we have is now that this device seems to be able to seal the appendix quite efficiently. So in this study, but also in many other studies, we have now seen that there is no significant leak using this device in the left atrial appendix. And this is the global AMULET registry that has just been presented at the TCT, and we will present the 6 months data at the EuroPCR Congress with a little more than 1,000 patients, and the paraprocedural safety for this device is also similar compared to the Watchman device. So we have a 2.7% paraprocedural complication rate, which is similarly to what we see now with the more experienced Watchman operators. Now, what is the outlook? I think we all agree that for this group of patients, the guidelines have pointed it out, we think this may be an interesting strategy. Those are patients with a very high bleeding risk and still a relevant ischemic risk. We have not yet data from randomized trials, and we are just starting a clinical trial called Closure AF in Germany, where the net clinical benefit of catheter-based LAA closure will be compared to best medical care in patients who have a relevant ischemic risk, so a CHEST-VASc score of more than 2, and a very high bleeding risk, so because they have already had a relevant bleeding or have a very high HAS-BLED score. About 1,500 patients will be included in the study, and it's in close collaboration between the German Cardiovascular Research Center and the AFNET, where we now are initiating this study. And I think there is another trial coming up in the Nordic countries that will also look in particular at patients after intracerebral bleeding. And so we will hopefully in the near future have also some data from randomized studies in this patient population. So I think the rationale is, of course, that the most frequent site of thrombus detection in the heart in our patients with atrial fibrillation is the left atrial appendix. There are some patients who cannot tolerate long-term anticoagulation, and for these patients it may actually be an interesting strategy. It has only been tested as far as now in warfarin-eligible patients, so we have not also yet the comparison to the NOAC therapy, which will be also a task of the upcoming trials now. And we clearly are in need of more data from randomized studies in patients at very high bleeding risk, and I showed you one of the trials that is now starting to address this question. Thank you very much for your attention.
Thank you very much, Ulf. We'll move on now to what about the left atrial appendage, the surgeon's view, and Manuel Castella